Hello and welcome. This is part of the pre-workshop module available as part of the Nurses in the Know workshop for CDC nurses that is happening at the Nell Hodson Woodruff School of Nursing in January. I was asked to provide an overview for treatments related to asthma and COPD and diabetes. And so this part of the module then deals with treatments for diabetes. Because the therapies for diabetes have really exploded in the last, even 10 years, I've broken this up into three smaller parts totally. So where we are now, this is part one, and we're going to be talking about therapy with insulin. Parts 2 and 3 of our diabetes, larger part, will deal with non-insulin therapies. So let's go ahead and get started. All right. Now the first thing I want to do is I want to uh, show you or discuss really briefly two important studies. The first is the UKPDS or the United Kingdom Prospective Diabetes Study, and the second is the DCCT, and this is a US study, the Diabetes Control and Complications Trial in the US. And the upshot of both of these is that when you have better control of blood glucose, you have significant decreases in morbidity and mortality, particularly with type 1 diabetes. Complications in the retina, the kidney, and the cardiovascular system also are going to be decreased in type 2 diabetes when you have tight control. I want to take you to this particular site here, and this is for the DCCT trial. I like this document a lot because it's kind of an executive summary. So you get kind of the high points of the study right away. It's an easy read. All right, so going back here, so basically we have to have we have to have adequate blood control or adequate control of blood glucose if we want to decrease the complications that are associated with diabetes, both type 1 and type 2 diabetes. Now this tight control has some drawbacks. The first of which is that you are more likely to have hypoglycemia when you have tight blood control. And hypoglycemia is a very significant and potentially dangerous adverse effect. Patients who have tight blood glucose control may have greater incidence of weight gain, and nobody really wants that. These kinds of regimens, because of the increasing number of therapeutic options that we have, the regimen for individual patients are going to be individualized, and they also can be rather complicated. This leads to greater inconvenience for your patient, which can also lead to less compliance. Many of the drugs, including the insulin therapies that we're going to talk about in a minute, are injectable, which means that your patient may need to self-administer numerous injections throughout the day, which also can impact their compliance. And then additionally, tight blood glucose control means that your patient is going to have to test their blood glucose very frequently throughout the day. And this ongoing blood testing, self-monitoring of blood glucose can actually increase the cost of their of management of their disease, and that may impact their compliance as well. All right, so this slide actually represents kind of a scheme of the large number of drugs that are now available. Okay, so you can see here I've divided it really roughly. So we have insulins, which we're going to talk about in just a second, and then non-insulin drugs, and that includes all of these drug classes. This has really exploded recently, and in fact there's a new drug class that was just approved in 2015 that I'm not showing here. I will show it in part 3 when we start to talk about these non-insulin drugs. And then I've got this other class here, and I just call it others because they're not really specific to the treatment of diabetes, but you may see them in a treatment regimen. Now, the story that I always tell here is that a long time ago, when I was a pharmacy technician back in high school, the only options you had to treat diabetes were insulin, and it was pork or beef. And so you would ask your patient, did they prefer pork or beef insulin? And that was it. That was all there was. So now we have many, many options here, which means that we've got a lot of strategies that we can use to provide very individualized therapy to reduce your patient's blood glucose. But this also means that their regimen, as we said before, may be very complicated. The second important point that I want to make here is that insulin is really a cornerstone therapy. It's always going to be the cornerstone therapy for type 1 diabetes. And you probably remember that patients that have type 1 diabetes have had damage or a loss of the insulin secreting cells in their pancreas. And so insulin therapy really represents replacement therapy with a missing hormone. But also type 2 diabetes. As patients progress throughout their disease, the beta cells begin to become dysfunctional and fail. And so those patients also may be using insulin as part of their therapy. All right. Now this is a graph that demonstrates, two graphs actually, that demonstrate first the time course of blood glucose release in the blood, over the course of a day. And you can see down here we've got breakfast, lunch, and supper. And so you can see that blood glucose fluctuates throughout the day in response to eating a meal, which makes sense. Okay. The bottom part of this graph actually represents insulin release, and this is normal insulin release in normal healthy people, and you can see that insulin release is going to follow the same pattern as blood glucose release. And so as blood glucose rises, then insulin will rise also. Insulin's job is to remove glucose from the blood, and so it makes perfect sense that the release of blood glucose then triggers the release of insulin, and insulin levels will spike. Understanding the natural rhythm of insulin release, whether it's following a meal or whether it's just the basal release of insulin throughout the day, because notice this doesn't ever go back exactly to zero. You can see that, part of this tight blood glucose control may be mimicking the natural release of insulin throughout the day. Okay, so on to our insulins then. This is a table that I made that shows, really I've divided these just into four sort of broad categories, and I've called these rapid acting, and sometimes you'll see these called rapid acting slash short duration. We've got short acting insulins. Sometimes you may see these called slower acting slash short duration. Intermediate acting, or sometimes you'll see these called intermediate duration, and then long acting or long duration insulins. And I've put here in this column, this is the onset, this is how long it takes for these insulins to begin working. And then I have the overall duration. And these are just, very broadly defined. So not hard and fast, but just very broadly defined. All right. And what I want you to see is that the rapid acting insulins here act rapidly, very quickly. Even the shorter acting, slower onset, short duration insulin still, 30 minutes to an hour, you're going to start to see these insulins begin to work with a slightly longer duration. And if we go all the way here to the long acting insulins, you can see that these can act for up to 24 hours. Sometimes these particular insulins are called basal insulins because they can be used to kind of get that basal insulin release throughout the course of a day. All right. Now, how do we get these different kinds of insulins? Well, there's really two ways. First is we can modify the insulin molecule itself. Insulin is a peptide, so by modifying the amino acids that are present in that peptide, we can change the insulin a little bit. And you can see this here, insulin aspart, insulin glucosine, and insulin lispro. These are all going to be three very slightly different molecules based on the substitution of a single amino acid. Okay, now the second way that we can modify insulin to get these different categories of activity is that we can modify the formulation. So by changing the formulation, we can change how the insulin is depoting in the body and how it's being released from that depot site and being dispersed to the rest of the body sites. So this means that by changing the kinetics of the activity of the insulin, then we can also change the regimen, or we can have that impact on your patient's regimen, and it's all about getting tight blood glucose control. Insulins are all going to be injectable. I will mention to you that there were two inhalable insulins that have recently been pulled off the market, mostly because of patient concerns about the inhalability and adverse effects, but also because patients did not respond to them very well. All right. Secondly, I want to point out to you that because insulins, the vast majority of insulins are injectable agents, they're going to require a lot of patient education about how to give the injection, about injection sites, about mixing insulins, about using their insulin pen, etc., etc. A lot of patient education is going to be required. Thirdly, I want to tell you that most of these insulins are actually going to be available by prescription. Some insulins may be available over the counter. For example, regular insulin and NPH insulin may be available over the counter. Additionally, you may still find beef insulin that's available online, and this would be available without a prescription as well. And some patients, particularly those without insurance coverage, may be resorting to those options in an attempt to regulate their blood glucose. So you should be aware of some of these issues that surround the use of insulin. Okay, now this actually represents kind of a graph. If we were to make a picture representation of the onset and the duration of these different insulins, you can see we would have our rapid acting short duration here with a quick peak and then it quickly falls off. We'd have our slower acting short duration here, our intermediate acting, and then our long acting here. And notice here, again, this is exactly why we call insulin glargine a basal insulin. Notice that there's not a very well-defined peak of activity here or a peak of onset of activity. And so you get kind of that steady release of basal insulin, throughout the day, which is something that can be, very useful as you're designing a regimen for your patient. I came across this particular document and I want to show it to you. I thought it was very handy. This actually comes from a prescriber education program in New York State, and this is something that they call Insulin Basics. So it gives you some very quick uh, facts about different kinds of insulins as well. It also gives you some information about available mixtures of insulin so that your patient can purchase these pre-mixed, and then also some really useful information about designing or about maintaining that blood glucose control, say on a sliding scale or adding prandial insulin, etc. I thought this was very practical and very useful, and I hope that you will too. Okay. All right. Now, adverse effects of insulin, very important to remember. Hypoglycemia is going to be the most significant adverse effect. This can be life-threatening. Patients will receive some signals from their body if blood glucose goes too low, including palpitations or rapid heart rate, sweating, nervousness, or weakness. But serious hypoglycemia can produce CNS effects, including mental confusion. Very, very important. And just to remind you, the brain uses glucose exclusively as its fuel source. And so when blood glucose goes too low, then brain function is affected primarily. Additionally, adverse effects of insulin weight gain. Now, this is also significant because many patients, particularly those that have type 2 diabetes, are already too heavy. And so when you're designing a regimen or when you're implementing a regimen to control their blood glucose, if they are significantly overweight, you may want to take that into account. The most excellent place for information about insulins and about diabetes management is, as you might guess, the American Diabetes Association. They also have a site, a very helpful site about insulin basics here. This is a great source of information, as you might guess, for your patients, but also for healthcare providers as well. So I would encourage you to go ahead and check that out. All right, so this brings us to the end of our quick overview of treatment of diabetes with insulins. Stay tuned for parts 2 and 3, which are going to involve treatment with non-insulin drugs. And